Hi, very good morning, everyone. Welcome to 2026. A very sure, very happy New Year. This is our first session for CMAAO International Weekly Meeting, and I welcome everyone on this board for a very happy New Year, a disease-free New Year, and a knowledge-based New Year. So this is our motto where we will spread knowledge and we will try to answer all the questions of people whoever has problems. To start the day, we would have a topic which is, I think, a very generalized, a very important, and a very talked about topic about diabetes. I think we all talk about what diabetes can happen, what it can cause, all whatever questions are there. People who want to join this session can join on Zoom. This session can be joined at 818-8591-1572. The topic for the today is atypical diabetes. To talk about this, we have Dr. Urman Dhurv. Dr. Urman Dhurv is a senior physician and a director of internal medicine at HCG Hospital, Ahmedabad, with over 3 decades of experience in clinical medicine, a distinguished specialist in diabetes care, a public health awareness. He holds qualification in MBBS and MD in internal medicine and LLB. His contributions to diabetes management, Dr. Dhruv has authored significant chapters and review articles and has been honored as a fellow of Diabetes India, a pioneer in adopting computerized medical records as early as 1998. He has developed a unique data-driven respiratory for nearly 10,000 patients. His work continues to shape national guidelines and community education in diabetes and hypertension. Sir, we are pleased to have you here, and over to you.
Thank you, everybody. Uh, Lots of good wishes for a very happy new year. I'll share my screen. Hope I am visible and audible both.
Absolutely, sir. Perfect.
Fine. So, what we are going to talk in next 35 minutes would be atypical diabetes, with a disclaimer that few of the presented cases have been received from our group's data. We are going to do it more or less case based so that it becomes little easier for everybody to understand. When I was studying in 1987, this is what my teacher used to tell: I can do anything except make insulin. And this is something that we knew, that everyone who is juvenile is type 1 diabetes and everyone who is elderly are type 2 diabetes. Unfortunately, that has been the myth even in 2026. And that's what we are going to break by today's presentation. So, what is atypical diabetes? A rarer form of diabetes which differs from the common forms of type diabetes, which are type 1 and type 2. Actually, whenever we try to fit the clinical scenario of few of the patients, it does not fit, neatly fit with a diagnosis of either type 1 or type 2 diabetes, and that is known as atypical diabetes. So let's start with a case. Mr. B is a 30-year-old lady, BMI 28, central obesity, borderline hypertension, strong positive family history. Mother and brother both are having type 2 diabetes. Presented with symptoms of frequent vaginal yeast infection and increased urination. And she had measured her blood sugar somewhere in a party which turned out to be 275, meaning thereby she did not have osmotic symptoms. HbA1c 10, triglyceride 216. So, very classical case of type 2 diabetes, office case that we see day in and day out. And so, obviously, she was started on OHAs, metformin and sulfonylurea with lifestyle modification. 6 months later, nothing changed. Obese, high BMI, so GLP-1 receptor agonist was added as per the current tradition. HbA1c did not decrease a lot, went to 8.5. So, as per again the guidelines, basal insulin was added to reach to a target of fasting blood glucose of 126. Once her blood sugar reached 120, she was placed on a blinded CGM, and something surprising was detected: a very high degree of glycemic variability, more so after eating, and multiple hypos at night. So we ordered an autoantibody testing. Fortunately, I'll explain you why fortunately I'm saying positive for anti-GAD, and later on we went in for other autoantibodies also academically, and they were positive. So now she was diagnosed as type 1 diabetes. Type 2 diabetic medications were stopped and started on intensive insulin therapy regimen. What would you call her? A lucky lady or an unlucky lady? Uh, Lucky lady, the reason is after such a long time, her autoantibodies remain positive. And that is what the lesson of the lecture is. If at all you are suspecting something atypical, go for antibodies at the earliest because they may wane. So she was lucky that we could get a diagnosis, unlucky because she would not be on OHS. So she presented like an adult with type 2, but actually had type 1 diabetes, misdiagnosed, placed on OHA, and did not have adequate effect. The combination of her age and lack of response to non-insulin therapies led us to measure antibodies and correctly diagnose her. Let's go to another case. Mr. H is 40-year-old Indian with a BMI of 23 kg per meter square, history of type 1 diabetes. Actually, he presented at a multi-speciality general hospital with mild diabetic ketoacidosis and pneumonia. Obviously, he was admitted and pneumonia was cured, posted on insulin. He had a strong family history of diabetes, both insulin and non-insulin requiring. His father and grandmother had the condition. He was on multiple daily insulin regimens since diagnosis, 5 years, but he used to occasionally forgot to take the insulin for a week or so without any issues. At a recent visit to our clinic, his laboratory results showed a fasting blood glucose of 123 with 4 units of basal insulin and a C-peptide level of 2.8, which shows a good pancreatic reserve. Testing was negative for anti-GAD and ZNT8 autoantibodies, although, as I said, 5 years later, a false negative is not unlikely. Metformin and DPP4 inhibitors were sequentially added to his insulin regimen. Pre-meal insulin doses were reduced and gradually withdrawn. And he was absolutely stable on metformin with DPP4 inhibitors. So this was a gentleman who had adult onset type 1 diabetes, but actually he had type 2 diabetes. Misdiagnosis meant appropriate treatment was delayed for 5 years. Individuals with type 2 diabetes, particularly those who are African American, can have decay at diagnosis and during period of illness. So the message: DKA does not always mean type 1 diabetes. Of course, this was actually A minus B plus KPD, which we'll see what it is later on. Just remember this case, we are going to mention it later on. The fact that Mr. H was relatively lean and young and presented with decay made the diagnosis of adult onset T1D likely, and correctly so, but this should have been immediately confirmed with antibody testing and clinical follow-up to determine which type of diabetes he had. So, the lesson: if you at all you find something atypicality, go for autoantibodies at the earliest, as early as possible. So, although it is said what is in a name, atypical diabetes has multiple phases, and we'll take few of them, not all, because we are supposed to finish within 35 minutes. So we'll take few of them. And first would be monogenic diabetes. Obviously, monogenic diabetes means it's a non-syndromic form of diabetes. Why non-syndromic? Because the presentation would be only diabetes and diabetes. No other system, nothing else would be affected initially. It would be Mendelian inheritance driven and damaging variant only in a single gene. That's why it is monogenic. A strong family history that typically follows an autosomal dominant pattern of inheritance. We'll see some autosomal recessive pattern also later on, but this is autosomal dominant pattern. MODI, that is actually the pronunciation is MODI. So maturity onset diabetes of young is a classical example of monogenic diabetes with 14 known subtypes, MODI 1 to 14 and many more are in the pipeline. So we go to the case number 3. 15-year-old male having type 1 diabetes 6 months back, osmotic symptoms with weight loss, fasting 140, BMI 21, no ketones, sugars ranging from 82 to 210, obviously classically treated with basal insulin 6 units, which kept his A1C 6.4 to 6.7 and sugars between 90 to 190. Younger patient, although male, one had to do thyroid function test, normal, get antibodies negative, C peptide normal, once again suggesting a good pancreatic result, and lipids were okay. What did we ask? We asked about family history and we got the news that his father had diabetes at the age of 23 with multiple microvascular complications later on. And his paternal grandmother also had diabetes in the teen, but she was overweight. So we remember this classical autosomal dominant monogenic diabetes where unaffected mother versus an affected father would lead to 50% MODI in the children. 2 out of 4 would have MODI. What did we think about this patient? Autoantibodies absent, less likely to be T1D, C peptide normal, again less likely to be T1D, BMI okay, lipids okay, again less likely to be type 2 diabetes. Strong family history. Could this be atypical diabetes? Yes, we sent in for genetic testing and it turned out to be heterogeneous for HNF1 alpha mutation, meaning thereby it was MODI3. What is the treatment of MODI3? We'll see. MODI3 is the most common form of MODI. Patients often develop insulin deficient diabetes in the second or third decade of life, and that's why they are diagnosed as type 1 diabetic. Microvascular complications are much more common with HNF1 alpha MODI, but the treatment remains OHA, sulfonylurea responsive. They are very easily controlled with sulfonylurea for at least first 5 to 10 years of life. So this is classical case where you can uh, take away insulin for a short period. Another case, 12-year-old boy diagnosed to have diabetes 3 years back. Polyuria, fasting 120 to 140, post glucose 210, A1C 6.5, and was on metformin, BID 200,000 milligram BID because he was obese, normal puberty. Multiple maternal relatives with diabetes, mother BMI 29, A1C 6.8 on glimepiride, maternal father had mild hyperglycemia. His own BMI was high, A1C 6.5, sent for genetic studies, and it turned out to be GCK gene. And what's the treatment? Let's see. So it is GCK MODI, which is the second most common form of MODI. Mildly elevated fasting hyperglycemia, mildly elevated A1C. And the pharmacological treatment? Well, no treatment is recommended except during pregnancy. So now one can understand diagnosing MODI is so significant. The reason is diabetes related complications are conspicuously absent. How do you suspect? Strong family history, absence of complication, and very mild hyperglycemia. Think about genetic studies. So MODI, together the subtypes of MODI account for 1 to 5% in a country of 140 crore population And in a country where you are having 40% prevalence of diabetes, you can count the number of MODI that must be moving in the population very high. Most common types are MODI 3 followed by MODI 2. MODI 2 accounts for 32%, glucokinase gene, and MODI 3 accounts for 50%. And these are different phases of MODI 2 and MODI 3 that you can see. The charts are always there in the textbook. They may present as normal weight children or young adults with mild hyperglycemia without any signs of insulin resistance, and so they are generally posted as T1D. But absence of autoantibodies and a strong family history should alert a doctor. Diagnosis is confirmed by genetic testing of high risk individuals, and the treatment ranges from diet lifestyle alone in MODI 2 to sulfonylurea in MODI 3 and insulin in few of them. So now you can say that MODI is probably the new era of precision medicine where we started prescribing sulfonylurea in a young diabetes. That is really very good. This is how you differentiate between MODI, type 1 diabetes, and type 2 diabetes. The most important point is always C peptide and inheritance. Two important things one should look for. One more case, 16-year-old male diagnosed to have type 2 diabetes, autoantibodies negative, multi-generational family history, C-peptide 0.52 increased after meal to 0.98, meaning thereby once again decent pancreatic insulin reserve. HbA1c 6.9, BMI 28, basal bolus regimen because he is only 16-year-old. Diagnosed with type 1 diabetes. History of unilateral nephrectomy at the age of 6 months. This should alert a clinician. Nephrectomy. Record shows cystic kidney, good C-peptide, good HbA1c, not very high BMI. History of renal cyst. Immediately get alerted in a patient who has got a strong family history, multi-generational family history. Scent magnesium, low magnesium level. Could this be MODI? Yes, it is MODI. It is MODI 5, where there is HNF1 beta problems, where it is associated with pancreatic atrophy, renal dysplasia, renal cyst, and very likely to go for renal insufficiency. So this was sent for genetic sequencing. MODI 5 HNF1 beta was found out genetic problem. It's also known as renal cyst and diabetic syndrome. USG showed small pancreatic and cyst. Generally, we avoid renal cyst, but in a younger diabetic, always think about MODI if there is a strong family history. So it's a non-autoimmune, non-insulinopenic diabetes, and SGLT2 inhibitors, GLP-1 receptor agonists, and metformin works well, but always keep an eye on renal function. So the message, not all teenagers can be a priori be presumed to have type 1 diabetes, and one should always keep in mind MODI. What are the predictive tests? Genetic counseling followed by genetic test for sibling. Now, this is something which has been debated a lot. It is a doctor's duty to offer genetic counseling for the siblings, explaining him the risk of development of MODI in his or her case. But you cannot force anybody to do it, but genetic counseling for the sibling is a must. Coming to neonatal diabetes, a few lines about it. Caused by loss of function variants in KATP channels, and generally KCNJ11 gene is affected. It is monogenic diabetes, occurs in first 6 months of life, but patient may present to you at 8, 10, 12 years, and you have to ask since what age he or she has diabetes, and if it is at the age of 6 months, immediately send the patient for genetic studies. The reason is this wonderful little girl. Who was she? She was Lily Jeffrey, who is a poster boy of precision medicine. The reason is she was diagnosed as neonatal diabetes, went in for genetic study, found out that there was definitely KCNJ11 mutation, and she could be very well managed for first 10 years of life with sulfonylurea. So that is very classical way of precision medicine, neonatal diabetes. Oligogenic forms of diabetes and syndromic diabetes. Again, a couple of slides about them. Syndrome means there are more than one system affected. Atypical diabetes is there. So in addition to hyperglycemia, you find multiple syndromes and multiple genetic mutations are there from a single molecular deficit. A positive family history may be seen in few of the patient, and it encodes protein important for beta cell development. However, their expression in other tissues can lead to multi-organ development. And the classical is Wolfram syndrome, which we also known as Didmore syndrome, diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. As we don't see a lot of cases, we can skip it and go to the next one. And that is mitochondrial and ketosis-prone diabetes. It's a new entity. Mitochondrial dysfunction can lead to mitochondrial diabetes. Very important to remember that here the treatment with metformin is contraindicated because it causes immediate lactic acidosis. How do you recognize? As I told you, a positive family history with maternal inheritance. If there is maternal inheritance, positive family history, think about mitochondrial dysfunction. I would like to draw your attention more to this KPD, ketosis prone diabetes, where the patient presents at the time of first complaint with ketoacidosis in the absence of characteristic features of autoimmune diabetes. Clinically and etiologically heterogeneous, four distinct subtypes have been found out. They are depending upon antibody positivity and negativity, A plus and A minus, and depending upon the presence of beta cell functional reserve. So you can have A plus B minus antibody positive, beta cell negative, KPD. It is very close to traditional autoimmune type 1 diabetes, but still the patient can be managed on sulfonylurea or OHA for a short period of time if you can diagnose it. A minus, B minus means antibody is negative and beta cell reserve is not there. Also resembles type 1 diabetes but does not have autoantibodies. A minus B plus. Antibodies are absent, but beta cell reserve is enough. Uh, Specifically, the subset term unprovoked A minus B plus nearly resembles type 2 diabetes, but they present with diabetic ketoacidosis despite the fact that they've got good beta cell functional reserve. I told you to remember this Mr. H, and as I told you at that time also, this was a classical case of A minus B plus who presented with ketosis. These patients are able to discontinue insulin therapy within 1 to 2 months after initial index episode of decay and may remain off insulin for several years, maintaining excellent glycemic control. People believe to have herpes virus 8 infection as a etiopathogenesis for development of KPD. This AB classification scheme has given us a lot of insight. Coming to the last portion, and that is latent autoimmune diabetes in adults. Very classical, everyone knows it very well. In fact, we can say atypical diabetes discussion always started from LADA, defined by presence of islet autoantibodies in the absence of insulin dependency for at least 6 months after initial diagnosis. Most of the time, these patients are misdiagnosed as type 2 diabetes. Frequency of LADA is quite high, 5% to 13%. Considering 90% of patients diagnosed as type 2 diabetes, you can understand the huge number of LADA that we see. It's a pathological overlap between type 1 and type 2, and that's why people also call them 1.5 diabetes. Mostly it is underdiagnosed, and the only thing that we can do is a widespread autoantibody testing in all patients with type 2 diabetes, which is not practical, which is not advisable. And looking to the possibility that autoantibodies may wane, looking to the lots of antibody assays that are available. This is not possible. So the only way we can do is suspect LADA and then go for autoantibodies. We have not covered these 6 types of atypical diabetes due to lack of time. This is very classical scenario where insulin sensitivity, insulin secretion, and islet autoantibodies would differentiate between different cases. A very important 2 slides which will explain you where to put atypical diabetes, especially the one from ADA. This is a very wonderful slide where there are 3 axes: insulin secretion, insulin autoimmunity, and insulin sensitivity. And they have placed all these atypical and typical diabetes on these 3 axes. We'll just go through a couple of them. LADA, you can see autoimmunity is present and insulin secretion is present. And same way, ketosis prone diabetes, antibody is present, beta cell function present. So they have posted it here. Just one more thing, like we can have a look at MODI. So where is MODI? Insulin sensitivity, there is insulin resistance, it is low. Insulin secretion is there, not profound, but autoantibodies are absent. So it has been placed there. So I would always suggest you to keep this graph or figure on your table. Last few slides, when to suspect atypical diabetes, when there is a family history, when the presentation and progression of a patient's illness is atypical, and few of the syndromes that you can see, like autoimmune, autosomal recessive in mitochondrial diabetes. Always look for lipodystrophy whenever a patient is on insulin, and looking to the areas and patterns, you can diagnose it. How do you diagnose? A few words about autoantibodies. Autoantibodies against GED65, islet antigen 2, IA2, insulin and zinc transporter 8 are available at present. Out of them, autoantibodies against insulin may be unreliable, especially if the patient is already taking exogenous insulin. So the rest of 3 should be done. They may wane with age. And that's why, once again, a caveat: always, always, always measure it at the earliest if you are suspecting atypical diabetes. Identification of high titers of multiple islet autoantibodies suggest autoimmune form of diabetes. And always remember, which are the autoimmune form of diabetes: type 1 diabetes, LADA, and A plus subtype of KPD, A plus B plus or A plus B minus. Very important is poor man's antibodies is C-peptide, serum insulin or C-peptide levels as a marker of patient's endogenous insulin secretory capacity. Insulin is not reliable, so we should go for C-peptide everywhere where you are suspecting atypicality. It is not a component of therapeutic insulin preparation, and therefore you can very easily get it done even in patients who are on exogenous insulin. Very important thing is MODI probability calculators are available online, where when you put age at diagnosis, BMI, insulin requirement, and HbA1c, it would give you a probability whether you should go for genetic test or not. And the genetic tests that are available, single gene tests are available, quite cheap, I would say, nowadays, from about 2,500 to 5,000 rupees. And as you have seen, it is going to clinch or change the life of a person if it turns out to be MODI 2 or 3. Molecular genetic testing, broad-based molecular tests are available. And last portion, how to approach to a case of atypical diabetes. Look for disease course, family history, physical examination, especially for markers of insulin resistance. If they are present, more likely to be type 2 diabetes, acanthosis nigricans, adipose tissue loss, or syndrome are any present or not. Very classical graph you'll find in all textbook. Approach to a case of atypical diabetes, age at onset, and then followed by, very important thing is blood glucose, C-peptide, and autoantibodies. 3 important things which would differentiate the two. Atypical diabetes has set a future dream of precision medicine, and that's why it is very important because in certain modi, you can avoid treatment except in pregnancy. In certain modi, you can continue OHA, especially sulfonylurea. In neonatal diabetes, can be managed with sulfonylurea. There are issues about the nomenclature of LADA, and people still believe that it is probably a transition period. Whatever it is still under atypical diabetes. So, discovery and description of these forms of atypical diabetes have led to major contribution to our collective understanding of basic biology. Concluding the session, recognition of patients with atypical diabetes is important because of the therapeutic and prognostic implication of this diagnosis. Patients with atypical diabetes have often been misdiagnosed as type 1 or type 2 diabetes, and in some cases committed to unnecessary insulin therapy and screening for complications, or committed to OHA and missed out on insulin, which may have caused harm to them. Maturity onset diabetes of the young is most commonly caused by a mutation in the gene encoding HNF1 alpha. Initial treatment is low-dose sulfonylurea therapy. It is caused by mutation in the gene encoding GCK. It does not require any treatment, that is MODY2. Type 1 diabetes diagnosed before the 6 months of age must prompt screening for neonatal diabetes because it can be managed very well by sulfonylurea. KPD should be considered in patients who are presenting with ketosis and type 2 diabetes phenotype with some atypicality. Think about ketosis from diabetes. Last slide. Latent autoimmune diabetes in adults can be considered as slowly progressive type 1 diabetes. Maternally inherited diabetes and early deafness are clues to the possibility of mitochondrial diabetes, and genetic molecular testing. Don't run away from them. Take most advantages of this genetic molecular testing, which are now very easily available in most of the cities. I'm sorry if what I said was said during my hypoglycemic events. Thank you very much.
Thank you, Dr. Dhruv, for wonderful, insightful, our first presentation in 2026. And I welcome Dr. Chong. He's the chairman for CMAAO. I welcome Dr. Anil Kakri. He's the president for CMAAO. He's from Nepal, and Dr. Chong is from Singapore. Dr. Chong, first day you are late.
Sorry, Dr. Dhruv, very nice presentation. Apologies to everyone. I was late. I just finished seeing my patient. We have a clinic on Saturday morning as well. So that's unfortunate. But I caught what you said at the last bit about all your different types of diabetes. And in Singapore, we have 11% of the population who are diabetic, and 1 in 5 at the age of 30, 1 in 5 at the age of 30 is diabetic, 1 in 3 at the age of 60 is diabetic. So we have a huge problem in Singapore. And I think it went from 10 to 11% in the last 5 years from pre-COVID to now. So it's gone up by 1% in the last 5 years. And a lot of it, as you've rightly pointed out, is type 2 diabetes. Here in Singapore, we don't have that much of atypical diabetes. Most of it is type 2. And therefore, a lot of it is due to our lifestyle here in Singapore. So not a great lifestyle, too much stress, too much carbohydrate, bad food. So thank you, Dr. Dhruv. Any questions on the floor for Dr. Dhruv?
Sorry, Angelique here.
Hi, Angelique.
I can't find to raise my hand. So just want to wish you all a very, very good 2026. And it's always nice to start off with this type of lecture. So I think listening to you, Dr. Dhruv, I think maybe we are missing a lot of wrong or diabetes patients that's maybe atypical, because we tend to classify before the age of 27 around, you are definitely type 1, and after that, you definitely type 2 diabetes. So it might be that we are missing this big time, and maybe some of those type 2 diabetes patients with whom we are struggling with to get them under control, and we keep on going back and say, you don't listen, you don't take your medicine. Maybe we have diagnosed them wrongly. Do you have any, excuse for this, do you have any guidelines for us when we get, let's say, a 40-year-old patient diagnosed with diabetes, positive family history, and what would be the first thing that we do? Should we just put them on, you make the diagnosis, the HbA1c is elevated, and you start with your metformin and your sulfonyl or whatever is on the market? Should we not do more testing on that specific patient just to make sure that you don't miss all of these new developments in diabetes? Thanks.
Right. So, in fact, the whole idea of propagating this presentation all across India, we have been doing it for last 2 months, is to just change the mindset of everybody that everything that you see in young is not type 1 diabetes, as you rightly said, and everything that you see in elderly may not be type 2 diabetes. And the only 3 things that we always insist is look for family history in second generation, very important. In this case, suppose the example that you have given, go for C-peptide in more number of patients. We may not go for autoantibodies in all patients looking to the financial constraint, but at least go for C-peptide. And third thing, look for insulin resistance markers. If you can see acanthosis nigricans or something, well, you can wait for some time. But C-peptide, I would suggest to use it more frequently, even in younger patients. And if you get a good beta cell reserve, you can wait. But if you don't see good beta cell reserve, although the patient is responding to OHA, then think about autoantibodies. Or if there is a very good beta cell reserve, the patient is on insulin, then think about MODI.
Thank you, Dr. Dhruv. Yes, that's one of the things I look for if I suspect something is a little bit strange about my diabetic patient. I usually do a C-peptide. That's probably my first go-to test. I sometimes also do insulin HOMA, HOMA score, which is also useful, but that's more. But I think the C-peptide is very useful. That's usually my first investigation if I suspect something is not right. Thank you.
Before I leave, thanks everybody, because for the first time after a long time, I have been amongst the stalwarts of medicine. So thanks a lot for inviting me. Thank you very much.
Pleasure is ours, Dr. Dhruv, listening to you. Any other questions from the floor?
Think something.
Sorry?
Dr. Monica has some comments in the break.
Yes. Monica, please.
Happy New Year, everyone. Thank you, Dr. Dhruv, for a fantastic and very pragmatic presentation to start off the new year. I think this is a good reminder, since this presentation affects so many of our patients, no matter what field that we are in. My field is with asthma and allergies, and I prescribe a lot of systemic steroids for many different conditions associated with my patients, and I'm always paying attention to their hemoglobin A1C and whether or not what I'm prescribing will cause any increased glucose levels. But my basic training is in internal medicine before I did training in allergy. So I think this is a really good reminder that as diagnostic therapies advance, so should our clinical acumen, that we should not forget to look at acanthosis nigricans and marry that with the advancements in technology and put it all together so that we can give more targeted therapies for our patients, or at least direct them to the right people like you to take care of them. What I'm just doing is I'm trying to provide in the chat a little bit of kind of an algorithmic approach as a summary of what you had just said, so that this could be beneficial to other people who weren't able to attend the presentation. And I think there's some more comments that are being put. Thank you.
Angelique is asked, can C-peptide testing still be done to patients on diabetic treatment after several years? Will it still be relevant? Dr. Dhruv,
Yes.
what do you think?
Yes, certainly. I already mentioned that C-peptide is not affected even by exogenously introduced insulin, because that insulin does not cleave and leave C-peptide in the blood. So C-peptide at any age, in any circumstances, or on any treatment, including GLP-1, can be performed in a fasting state along with simultaneous blood sugar.
Speaking of monicus acanthosis nigricans, I just saw a patient with one about 2 weeks ago. And classic, all nice and furry, black furry appearance around the neck. And he was a bit big.
And that's
So,
why
yeah.
in diabetes, that's why management of diabetes is no more restricted only to investigation. We need to talk to patient and we need to examine the patient.
Yeah, I think the emphasis on clinical medicine is always forgotten, and we always rely on technology. And if we rely on technology too much, we become a postman. Clinical medicine is still so important, starting from the time of the Greeks 2,000 years ago, Hippocrates and so on. And we developed so much knowledge. And really, technology has only come in the last 2-3 decades. Before that was all clinical medicine for 2,000 years. So amazing. Thank you. I totally agree with you.
Thanks, everybody.
Okay, if there are no questions, thank you very much, Dr. Dhruv. And
can we have a take-home message for all the patients who are watching as a
yes. Dr. Dhruv, take-home message
for atypical diabetes?
Try to find out the family history in your family if you are a diabetic patient. If your diabetes has started at a younger age, volunteer to go for C-peptide test and contact your doctor whether genetic studies are going to be helpful to you or not. But most important as a patient would be trying to find out the family history in 2 generations. That would help a lot.
Thank you, Dr. Dhruv. Great take-home message, and Happy New Year to everybody listening in. And we hope to see you again, Dr. Dhruv, in the near future. And everyone have a good year ahead.
Thank you.
Disease-free year.
Thank you very much.
Excellent presentation, sir. Congratulations.
Thank you very much.
Thank you.